evening. Great to have you along. This is our second time of sharing this seminar, and this time Katie and I are thrilled to be here because last time, due to family emergencies, I think half an hour before we were due to present, Katie's child fell off the trampoline and ended up in ED, and something similar happened to me the day before, and we were replaced by Avina. So we're thrilled to be here today and sharing our tips and pearls about paediatric asthma with you all. Before I begin, we'd like to acknowledge the traditional owners of the lands in which we're meeting and pay our respects to elders past, present and emerging, recognising that we are spread out across Victoria on different lands. And also just to provide a brief introduction to the service, I'm Jo, I'm a paediatrician. I'm also the director of the Victorian Virtual Specialist Consult Service. Katie is our clinical nurse educator in paediatric asthma. And we offer free consultations with specialists. You can see the range of different specialties we offer to really provide an alternative to outpatient referral, which we know can be quite a lengthy process and result in delays in achieving the care that is needed and failure to optimise care. So this is going to continue to flash up. We wanted really to make this as interactive as possible. So we wanted to talk through a couple of cases, and these cases are based on pretty similar conditions that we see. Both Katie and I work together in the complex asthma clinic at Royal Children's Hospital, and Katie continues to see patients through VVSC, and I manage asthma all the time through VVED, and there's a wide variation in practice in some of the cases we're going to share tonight. So the first case we wanted to talk through was Betsy Miggins. She's 3 and she presents to VVED, and hopefully everyone on the call has heard of VVED. We are suggesting to patients across Victoria that your options for emergency care are lights and sirens if you're really sick. And if you're thinking of jumping in your car and driving to a hospital, consider using VVED instead. And the reason for that is in children, at least, we're able to keep 90% of patients at home through virtual management. And even those that do need to go in, we can get first aid management going. We can get them to the right place at the right time. So Miss Betsy Miggins knew about VVED and she's reached out for an emergency assessment. She's had a couple of days of cough, coryzal symptoms, and then prior to presenting, she's had 4 hours of working harder to breathe. The virtual assessment shows that she's got a prolonged expiratory phase, she's tachypneic, she's working hard to breathe, she's got an audible wheeze, and luckily they've got Ventolin and a spacer at home. And so they start burst therapy. Now, obviously we wouldn't recommend burst therapy at home outside of a recommendation from a respiratory specialist or under the guidance of VVED, but we have shown that this is safe and effective if done properly in the home environment. So with Betsy, she gets her burst therapy at home and has a really good response to that and is able to reduce her Ventolin requirement to more than 3 hourly after that. She's got a pretty unremarkable background history, other than this is the 3rd time she's presented with a similar exacerbation of asthma presenting to the emergency. The first 2 times were to the physical ED this year. So very keen to hear what is your diagnosis for this child. If you can pop it into the chat, it would be really great to see what are people wanting to diagnose Betsy with.
Viral exacerbation of...
And I've just realised I'm not going to be able to see the chat. Just going to jump on here. All right. Just, yeah, throw some diagnoses in there if you can, or feel free to unmute yourself and share what diagnosis you'd be giving this child. Be great to get a couple of answers. An Ertie with asthma exacerbation has come through. Can we have someone else throw out a diagnosis? Yep, great. Perfect. Secondly, would anyone here start steroids? Maybe hands up if you'd start steroids.
She's doing burst therapy.
A couple of people starting steroids. Excellent. Okay. And hands down, who would start a preventer for this child? You can leave them up if you'd start a preventer. Right. Only one person. Okay. So back in the day when I was training, which is, I reflected on this a frightfully long time ago now, preschool wheeze or viral-induced wheeze or bronchodilator responsive wheeze were all diagnoses we use for this cohort of children. They would then be discharged home with a asthma action plan, and parents were really confused. They were told this isn't asthma yet. But there's a chance your child will have asthma when they're older. We also used to think that we would be able to tell who would get asthma and who wouldn't get asthma based on what sort of presentation they had. So the children who were just presenting with wheeze were thought to be one group of children, with viral exacerbations were thought to be one group of children, and those who had multi-trigger asthma, so they might have some cough or wheeze when they were playing in the playground or laughing, they were thought to be a different cohort with a higher risk. That's all been debunked. There is no way we can tell in these toddler children who will grow out of asthma and who won't. It is asthma. Any child who presents with symptoms of asthma, wheeze, cough, that responds to bronchodilators is asthma. About 50% of these children will indeed grow out of it by the time they reach school age, and we can't tell which children those are. The reason why it's so important to call this asthma is it then leads you to follow the asthma guidelines. And these have also been updated in recent times. So Katie and I were both involved in the rewriting of the Royal Children's Hospital clinical practice guidelines. And at the time where we introduced this as a preschool asthma guideline, it was actually really controversial, and there was a quite robust discussion around it. Thankfully, there's now broad agreement. So Gina is suggesting the same in the UK. The Australian National Handbook now also refers to preschool asthma, and the thresholds for preventers have also become a little bit universally standardized. So preschool asthma is the diagnosis. It reduces confusion for families, and it allows us to treat this exactly as we would treat asthma in any other age group, which is to use a bronchodilator therapy. In the preschool group, however, if they are not being admitted to hospital, we don't recommend steroids. And this is based off a study that was done some years ago now in New Zealand, where they looked at the role of steroids in preschool asthma. So they had almost 500 children. They randomized them. Half got 2 milligrams of pred, so a pretty decent dose, and half got a placebo. And what they showed is that there was no difference in their respiratory scores in 24 hours, their resolution of symptoms, or their symptoms at 7 days. What they did show, the cohort who did have some benefit from steroids were those that went on to get admitted were less likely to need escalation in therapy. And so steroids are recommended if you're admitted to hospital, but for all preschoolers being managed in the community or who respond in ED to that burst and are going to go home following that initial burst, steroids are no longer recommended. And the evidence has flip-flopped on this, but that's pretty consistently recommended these days. So for little Betsy Miggins, who responded to that burst therapy, she's now stretching easily to 3 hourly. We wouldn't be using steroids in her. However, what has become increasingly recognised is that this is an inflammatory condition, and we know that airway remodelling starts really young, so we want to be managing that inflammation as best we can. So the threshold for starting a preventer has come right down. So any child who has interval symptoms, so that's needing Ventolin more than twice a week during the day or twice a month overnight, or if you have more than 4 exacerbations of asthma during the year, or more than 1 hospital presentation. So the first presentation to hospital, we wouldn't be starting it unless those other features existed, but on the second hospital presentation in the year, we would certainly be recommending starting a inhaled. I'm just going to mute whoever that is, sorry. we would certainly be recommending starting preventer. The first line preventer for preschool children is Flexitide. Many of you will remember the controversial move where this became a restricted medication that was overturned. So Flexitide Junior, 50 micrograms BD is the starting dose. If there's no response to that, so after 6 weeks, you'd be wanting to see symptom control. If you were still getting regular symptoms more than twice a week or symptoms overnight, you would then increase that to 100 twice a day. And if you're still getting symptoms there, you would consider the addition of Montelukast. Montelukast, obviously, you would counsel the parents around the 1 in 6 children that get behavioural effects. It's really difficult to tease out whether that's just normal toddler behaviour, whether it's the medication. If you think it could be the medication, the best way to test that is to stop it, see if the symptoms resolve, and then potentially retrial it if you think that medication is truly needed. If on 100 milligrams of micrograms, of Flexitide twice a day and the Montelukast, you've still got poor control, that's when you would refer in to see a specialist or do a co-consult through VVSC. And obviously we've talked through this, so daytime symptoms a couple of times a week or needing the reliever. And it's a really good practice to ask your patients how many canisters of Ventolin are they using. Parents have terrible recall. I have terrible recall as a parent. So if you ask me how many times I've given my child Ventolin in the past week, you're unlikely to get a good response. But if you ask when was the last time you had to replace your Ventolin inhaler, and if that's happening more than every 3 to 4 months, that's a warning sign that they're using too much Ventolin. What we're aiming for with the preventer is to be on the lowest dose that controls their symptoms. So if you get good control over a 6-week period, you might try and step that down. For most of these children who are predominantly triggered by viruses, we often use cup day as a point in time where we might look to reduce the preventer therapy. And a lot of these children will be on a preventer over the winter period where we know there's a high viral load, and then we get them off it over the summertime. So moving on now, I'll just pause there and see, does anyone have any questions about our first case or the management of preschool asthma? Feel free to come off mute or pop it in the chat.
It's Dominic here.
Hello.
With that study that you mentioned about steroid use for acute severe attacks, did it include kids that had severe atopic symptoms? Like when you said some didn't require steroids. So does that include kids who usually have severe atopy?
So in this age, I mean, in the preschoolers, that's mainly going to be eczema, as I think you've popped in the chat. So it didn't differentiate. It was mainly looking at the asthma symptoms. What I would say is obviously both are inflammatory conditions. There's obviously a genetic component to atopy. And we know that allergic march, that allergic triad where you start with the eczema, you then get the asthma, and then you get the hay fever. There's not such a tight correlation between eczema and asthma, but there certainly is in this age group, the school age group and older, with hay fever. And children with hay fever, it's really important that you manage those symptoms. And we start a lot of those kids on nasal steroids to optimize their hay fever management, because we know that impacts their asthma control. The same is not quite true of eczema, but what I would say, and Katie would agree with this, is we see lots of kids in that preschool group that have been started on a course of oral steroids in the community every time they've had an exacerbation, and they might be up to their 12th course of oral steroids in a year. That's obviously a huge amount of oral steroids for children at that age to be having. And so really we're trying very hard to get that message out that if you're not needing admission to hospital, you don't warrant the hammer of a dose of oral steroids, but that one course of oral steroids per year is too much. So we really want to be using preventive therapy earlier. And because it's inhaled, you don't get the same systemic effects. An entire year's worth of inhaled steroids has about the same amount of systemic effects as one course, or has less than one course of oral steroids. So we really want to be shifting from using oral steroids, particularly in preschoolers, and trying and controlling the using inhaled corticosteroids to prevent those episodes. Does that answer your question?
In a sense, yes, but like if those kids are already on steroid inhalers like Flixotide, and we are concerned that this is an acute severe attack, you reckon like the wait and see option with up titrating their steroid inhalation dose is okay, especially with I'm from a regional area, so where you don't have direct access to hospitals, everyone doesn't have. So yeah.
Look, I think, and we've been seeing these kids come through VVED, and I confess, if I see a child who's living in a really remote area, some distance away from a hospital, I'm much more likely to consider oral steroids if I've given them burst therapy at home. So I think, Dominic, in answer to that question, yes, I think these are guidelines. We're trying to standardize care. I think there's always an art to medicine. There's always an element of pragmatism. We do know that this reduces your need to have higher level, hospital level care, such as IV medications and admission to hospital. So I would say if your child is got a moderate to severe episode, even if you're able to keep them out of hospital, that probably is the cohort I would give oral steroids to. The child who's just needing a couple of puffs of Ventolin every 3 to 4 hours, I would not be giving oral steroids to. So I think there is a level of pragmatism that is needed when you take into account access to hospital and healthcare. But the broad message is, in those children that are having frequent exacerbations, but they're mild, they're managed in the home environment, try and avoid the oral steroids. And if you are in a situation where you're giving oral steroids, really optimize their preventive medication. And certainly in a preschooler who you're giving oral steroids to and who's already on 50, I would definitely be going up to 100.
Thank you.
All right. So moving on to Toby, who is now a school-age child, but presents with almost an identical presentation. So a couple of days of cough coryza. He too presents to VVED with a 4-hour history of having worked a little bit harder. He too has a forced expiratory phase, widespread wheeze, and he responds to the burst therapy as well. And it's also his third presentation. So in Toby, would you now give steroids? If you just pop in, actually just pop up your hand like we did last time. Who's going to start steroids for Toby? No one. One person. All right. And just pop in the chat if you would start a preventer for Toby and which preventer you would be considering for Toby. Give people a few seconds if you want to throw out a suggestion. Feel free to add that to the chat. We'll move on. So in school age group, there is evidence for giving steroids, and the dose of steroids that we use is 1 milligram per kilogram. This is based off a study where they compared 1 to 2 milligrams of steroids, and they showed that both doses were equally effective. They had the same impact on all those outcomes we talked before, but the ones that had 2 milligrams had much higher side effects. So they had vomiting. So there is no benefit to bump the dose up to 2 milligrams. So we stick with 1 milligram per kilogram. But in the school age group, it certainly has shown a strong anti-inflammatory effect for any child that reaches hospital and has an exacerbation of asthma. In terms of the preventer, we tend to recommend ciclicinide. So ciclicinide is a prodrug. Its major benefit is that it's once daily, but it has some other benefits. As a because it's once daily, it's half the price. You're only using half the puffs. It's half the side effects. It's also a prodrug, so there's less side effects. It's half the environmental harm. So all of these inhaled devices have a carbon footprint. Obviously, we want children's asthma to be well controlled, and we want to be avoiding using lots of salbutamol, so it's certainly better to be using a preventer in terms of environmental harm, but the less puffs, the better. The other advantage of Alvesco or ciclicinide is the PBS approved dose for Flexitide is 125 in school-age children, and we know that probably 50 in many of these children is adequate, and so it doesn't allow you to treat at the lowest dose possible, whereas ciclicinide you can use 80 micrograms, which is equivalent to the 50 BD of a fluticasone. So that's another good reason why ciclicinide, in my opinion, is a really good choice. And obviously, if you're only needing to use it once daily, that overcomes half the battle with the adherence as well. So really the take-home points from these first two cases is don't get hung up on the name. This is all asthma. We can get rid of all those different names we used to use for toddlers with wheezy episodes that responded to Ventolin. Treat it all as asthma. Keep the language consistent for the parents. Have a low threshold for starting a preventer medication. Be judicious in your use of oral steroids, particularly in that preschool cohort where there's been no evidence that it affects any meaningful outcomes outside of the hospital setting. And Katie will talk through all the other things that we should be thinking about in terms of what is their adherence to. So Dominic, back to your patient, were they actually taking their preventer that you'd prescribed them? Do they have an asthma action plan? Do they understand when they need to seek help? And are they using their inhalers effectively? So what is their technique like? But we'll move on now to talk about our teenagers. So Missy Higgins is a 13-year-old who presents with frequent episodes of chest tightness, cough, difficulty breathing. She's been using salbutamol. It works like a treat, and she's used 3 inhalers in the past year. So hopefully everyone's got alarm bells ringing at this point. And I hope that this has become pretty standard, that management for these children. But in the interest of time, we'll just push on and talk through what that should be. So back when I was at med school, we learned that when you had an asthma attack, you would use a reliever to get rid of that spasming. If you got lots of those attacks, that's when you would start a preventer, and then you'd obviously up the dose of preventer to try and stop getting lots of attack or to reduce those persistent symptoms. What the survey that was done by the National Asthma Council showed was that young people, so 12 to 24-year-old, over half of them had poor asthma control. 90%, so 9 out of 10 young people had symptoms in the last month. And over half of them, this was impacting their quality of life. So Katie and I see lots of patients through our clinic that aren't able to engage in their sport of choice. They're missing days of school. This obviously has impacts on their ability to maintain a level of fitness, their academic achievement, and subsequently their mental health and self-image if they're falling behind at school or not able to participate in their school. So it's got a significant impact. 60% of these children, I suspect that's at probably an overestimate, were taking their preventer medication, and very few had an asthma action plan, and 1 in 10 of them was smoking, which obviously impacts asthma control as well. So really, we're stuck with this problem that kids are still dying of this condition. Obviously, if you're in the right place at the right time, asthma is very treatable. But if you present late to hospital, if you're in a rural regional location, Dominic, if you're caught without the right treatment and in the wrong place, then this is a lethal condition. And we know that teenagers under-recognise and underreport and therefore undertreat their symptoms. We also know that this is an age group that is poorly compliant, and preventers require compliance. And the Lancet Commission that was published suggested that we should have zero tolerance. So one asthma exacerbation is one too many. We need to stop these kids having symptoms. This is a systematic review of over 68 studies that looked at the risk of getting an asthma exacerbation. And you can see right at the top there, previous attacks and persistent symptoms are two of your highest risk factors, but number 4 on the list there is suboptimal inhaled corticosteroid use, which clearly is the case for over half of these teenagers. This is a scary graph. It shows your risk of having a significant event goes up with the more reliever use that you use. So more reliever, greater risk. And here's the inverse, less inhaled corticosteroid, greater risk of death. So these studies, the Sigma 1 and 2, came out, I think, 2018, but they were relatively revolutionary in their time in terms of how they've changed the management of asthma in teenagers and adults. And hopefully this is all old news to you. So this was a year's study, over 4,000 patients, 12 and adults, who were randomized to 3 different groups: reliever therapy only, anti-inflammatory reliever treatment where they were using it with symptoms, or typical treatment, which was inhaled corticosteroids. And what they showed, this is the main graph to look at. The blue line here is reliever therapy only, and both the twice daily inhaled corticosteroid and the as-needed Symbicort were equally effective at reducing your chance of having a moderate to severe exacerbation and the time to having a moderate to severe exacerbation, so equally effective. Sigma 1 had twice daily reminders to remind people to take their inhaled corticosteroids, and the compliance was around 80%. So even with twice daily reminders, we were still sitting at 80%. Sigma 2 was more of a real life study where they didn't get the reminders and the compliance fell to about 64%. And then when they looked across both those studies in teenagers, what they showed is, again, that the Symbicort as needed was as effective as twice daily inhaled corticosteroids. But over the study period, the teenagers were taking a quarter of the steroid dose, and there was an impact on their height of 1 centimetre over the study period. This is a systematic review or meta-analysis of 6 different studies looking at moderate to severe asthma and SMART therapy, so twice daily Symbicort with PRN Symbicort for symptoms. And across the board, it shows that it is superior to inhaled corticosteroid, both for your time for first attack and your number of severe attacks. So putting all that together, for mild asthma, PRN Symbicort, as needed Symbicort, so taking a combination of both your reliever therapy but giving you some anti-inflammatory treatment every time you need it, is far better than reliever therapy alone. And it's as equivalent to inhaled corticosteroids twice a day. Has the benefits that you don't need to remember to take it twice a day, overall less steroid and less impact on height. For those with moderate to severe asthma, SMART therapy, so twice daily Symbicort with PRN Symbicort with symptoms, was better than twice daily inhaled corticosteroids. So rather than what we were all taught at medical school, some of you may be much younger than me, but what I was taught, which was reliever for symptoms, and then as you get more symptoms, start titrating up the inhaled corticosteroid, that's been completely flipped to one medication for both preventer and reliever. Starting off with PRN for mild asthma, just take it when you need it, have that dose of steroid on board as you get symptoms. The more symptoms you get, you're naturally titrating up your anti-inflammatory. And the advantage of it being a turbuhaler as well. So a turbuhaler doesn't require a spacer. You can slip it into your pocket. It's more environmentally friendly. For those children that don't enjoy a turbuhaler or find it difficult, there is the option of a Rapihaler. The Rappihaler, it is advised that you prescribe it in 2 puffs. It's the only inhaler where 2 puffs is recommended, and obviously you need a spacer. Just wanted to touch on the environmental impact. I've touched on this a couple of times. The inhaled devices all have a huge carbon footprint. So we should be aiming to have children on a single puff if we can. So those children that you titrate up to 2 puffs of Flixitide Junior twice a day, if you know they're going to be on that for some time, you're better to flip to the 125 once a day. That's cheaper for the families, the inhaler will last longer, and it also has half the environmental impact. For children who can use a DPI, that's an option. Children from about the age of 6 have been shown to be effective at using a DPI, and obviously teenagers and above, you should be preferencing a Turbuhaler if the patient can use that over an inhaled device, both for the reasons of it being very easy to slip in your pocket, but also from an environmental perspective. I'm going to hand over to Katie now to talk through some of the other factors that we need to consider in asthma management.
Thanks, Jo. So yeah, I'm just going to touch a little on some, education that we want to be focusing on for the patients and their families, of course. When we're talking about children, we want to also consider their carers and their parents who'll be guiding them. So in terms of the Turbuhaler, the technique is obviously quite different to using a MDI and spacer. So we want to make sure that the adolescent has really understood the technique. So first things first, it must be upright. We don't want to be spinning it around the wrong way. I've seen kids holding it horizontally. It's not going to work. So upright, we want to twist it one way and then back, and we want to hear that click. And the important thing is that moisture equals not so good, it's bad. So we want to not breathe into it. So we want to instruct them to take a deep breath in, but don't breathe back out. Once they've had that strong breath in, we want to get them to hold their breath for about 5 to 10 seconds if possible. Then move the device away from the mouth and then take that breath out. A couple of other things to just educate them on as well is always be checking that dose counter on the side. It does turn red when there's about 20 doses left. So just educating them to be mindful of that and to be purchasing a new inhaler ahead of time, because if we're also going to be using it in terms of a reliever therapy, we want to make sure there's plenty of doses there ready for an emergency or for an exacerbation where they might need more than usual. One way to check as well if the technique is adequate is you can pop a handkerchief, a dark color handkerchief over the top, and just get them to take that breath, and you should see some of the powder there if it's been a really effective breath. So little tip. Next slide, please, Jo. So this is the SMART action plan, which is pretty standardized these days. So this is the go-to that we've always used in our clinics for anyone over 12 who's on the SMART therapy. So that's the VVED dosing, daily dosing, and reliever therapy. So this, as an example, is a Turbuhaler. There is also a different one for the Rappihaler. Essentially, you want to just, like you would on any action plan, you're popping in their daily dose, whether they're having 1 or 2 puffs BD. Some children might have really, really mild asthma and really infrequent symptoms. So they might only need to use this as a PRN device. So you would have them on 0 BD, but they would then have 1 inhalation PRN. Other things to pop down in that free text space too is, for example, if they're needing to take doses pre-exercise, you would pop that in there as just a bit of a prompt. And then that will be their normal day-to-day plan. So the green zone, this is what we do each day. Obviously, moving into that flare-up stage, if we're in that orange zone, if they're having a bit of an exacerbation, we want them to be using this as their reliever, but we want to be mindful of the total number of doses that they might be reaching. So if they're on a 200/6 BD dose, they're already using at least 2 doses per 24 hours, and the maximum they can safely use at home is 12. So we always educate our families around, if you're heading towards that 12 in the 24 hours, you want to consider seeing your GP. And we would probably say even do that sooner. When you're getting to 6 per day, contact your GP and have that conversation, that review around, do we need steroids? Do we need to go to hospital? What else might we need to do here to manage this exacerbation? If they're obviously then moving into the red zone, we then want to consider calling an ambulance and continuing to take the Symbicort until the ambulance arrives. The difference here that we can do is if they are too unwell to take that Turbuhaler, or if they have Ventolin and a spacer at hand, they can revert to that typical standard 4x4 first aid plan that we use for Ventolin, being 4 puffs every 4 minutes until the ambulance arrives. So they can choose to use one or the other, but essentially we want to obviously keep treating until the ambulance arrives. Thanks, Joe. So then obviously going to hospital, reiterating what I've just said. So more than 12 actuations per day, we need to get to hospital. We can convert to the SABA if we want to with that 4x4 first aid via the spacer. Obviously, if they've done that and once they're in hospital, the standard treatment would be with a SABA, but upon discharge, we want to get them then back to their budesonide formoterol. So they go back to their SMART plan. The Ventolin, the SABA is really just for use in hospital, not at home. So just some education points to remember, you know, when you're discussing a new medication, a new plan with the family, or it's a new diagnosis maybe, everyone obviously should be on an asthma action plan. We want to make sure that they understand those signs and symptoms. So can they describe to you, you know, what's mild, what's moderate, what's severe? What am I looking for in my child? Am I looking for tracheal tug, subcostal recession, wheeze, cough, difficulty speaking, you know, the usual signs and symptoms, but we want them to be able to respond, recognize and respond appropriately. So we want them to be giving for those mild symptoms, maybe only a couple of puffs, if that's effective. If obviously the symptoms are more severe, we want them to understand that, you know, in those over 6-year-olds, they can have up to 12 puffs of Ventolin every 3 to 4 hours, and that is okay. So we don't want to be over treating or under treating, obviously, at home. We want them to understand at what point do they need to seek medical review. So, you know, they might be giving this much Ventolin every few hours, but this is going on for too many days, or our Ventolin requirement is getting closer and closer together. So we have a 3-2-1 rule, we like to call it, in our clinics. Essentially, it's a general guide for families to understand, hopefully quite clearly, quite quickly, if they're in this situation. If our Ventolin is lasting at least 3 hours, or only 3 hours, we need to see a GP. We want to catch it early and have a review, but we don't want to be in an emergency situation if we can help it. If our Ventolin is only lasting 2 hours, we need to consider going to the local hospital, or we want to contact Virtual ED. So we don't want to be sitting at home giving 2-hourly Ventolin without supervision or medical review. We need to be seeking hospital review. And if we are only getting an hour or not even an hour of relief between doses of Ventolin, we need to consider calling an ambulance. And we want to be really pragmatic about this. We would rather have families contact the ambulance for help and then it not be needed than them to sit at home giving 20-minute burst therapy at home unsupervised, and then we get into the danger zone, of course. So the other thing to consider, of course, is our inhaler technique. So for our MDIs, we want to shake between every puff if we can. Parents often will say, my toddler does not tolerate that. It's the middle of the night. They are miserable. I cannot do it. We educate really. We just say as much as you can, shake between each dose of each puff. And then for every puff that you give into the spacer, we want 4 good deep breaths. We want to hear or see that valve in the end of the spacer moving or clicking. And we know that they've got an adequate 4 breaths before we do the next puff. Obviously, with the DPI that we've just discussed, it's that twist and click, that strong inhalation breath, and then hold for a few seconds. And there's some really great education videos as well on the children's website or the National Asthma Council as well, especially around the Turbuhaler. So we always send a version of one or the other, whichever one is relevant for the patient, but for them to review that, and then they can go back and refer to that if they need to as well down the track. Obviously, adherence is a big one as well. If we're not taking our medications as prescribed, then they're not going to be very effective. So we often will ask, rather than how often do you forget to take your inhalers, how many times do you take your inhalers? So often they're quite honest when you ask in that way, and they'll usually say, we're really strict. We set a reminder in our phones. We never forget. Or, you know, to be honest, the morning doses are really difficult for us when we're getting out of the house. So it's about just reminding them of the importance of that regular dosing. The medications are not going to work as intended if we're not taking them consistently. And then, of course, heading into the flu vaccine season or flu season, you know, around that April time when the vaccine becomes available, just again, educating the families around the importance of the influenza vaccine for this group of patients. We all know the risks that come with influenza in children with asthma. So always just reminding them at every opportunity to have that when they can. Thanks, Jo. I'll hand back over to you.
So really that's what we wanted to share tonight. I guess it covers some of the key themes we see presenting to clinic. So, you know, a key take-home message would be that be very wary of those kids that are on bronchodilator therapy or reliever therapy alone. There is a small cohort of preschool children or school-age children who have very mild symptoms and are taking using their inhaler very infrequently that you can get away with that. Any teenager should be on Symbicort, and any younger child who's using more frequent reliever, strongly consider early introduction of a preventer. Obviously, Symbicort, I hope this is pretty mainstream now. It is as effective or better for almost all asthma types in that teenage and above adult cohort. Interestingly, there are now studies in the 5 to 12-year-old, and I think it's a matter of time before we see it introduced in the younger children as well. And if you had a child who you were having difficulties controlling in that 10, 11-year-old age group, it would be certainly very reasonable to flip them over onto Symbicort slightly early. Turbuhalers are great, environmentally friendly, slip them into your pocket. I noticed someone made a comment about how teenagers don't like to be different. It's much easier to have a turbuhaler in your pocket than to be carrying around a spacer. And then consider all those check that you've got the right diagnosis. You know, if they're not responding to the reliever therapy, it may not be asthma. We didn't talk about modifiable factors other than the allergic rhinitis in that preschool group and teenage group that have allergic rhinitis. Really important to manage that. Obesity can play a role. So if they're overweight and have poorly controlled asthma, that's something that you might want to address. Smoking, obviously, very difficult to counsel children out of that one, but it's important to know if they are smoking. And what are some of the other, I guess, environmental factors, Katie, would be another thing. If there's a clear trigger, we get a lot of people that know that in pollen time, they're going to need to up their preventer. And there was one other modifiable factor that, kids who have peanut allergy, really high risk. Teenagers with peanut allergy, please make sure their asthma is well controlled. They are some of our highest risk children. And then obviously make sure that the medication you think they're taking, they're actually taking, and that their technique is allowing them to get that dose. Katie and I would like to stop talking now and open the floor to any questions that you have for us. Preschool asthma with croup, absolutely. You would treat the croup with steroids. Yeah, we always say you've only got one airway. If that airway's getting inflamed and you've got stridor, get the steroids into them. Yeah. But just to be clear, you're using the steroids for the parainfluenza and the croup rather than for the asthma. And they often do, obviously, they often do exist together because croup can trigger the asthma symptoms. Yes, we have recorded it this time. This was part of the reason for offering it a second time, was the first time didn't get recorded. And Katie and I wanted our turn of jumping on and meeting you all. So we've represented it and recorded it this time. Out of interest, did anyone come to the first seminar that Avina ran? No, it was exactly the same presentation, just different presenters. Any other questions? Feel free to come off mute and to...
Dominic again, with switching steroid inhalers, like for example, from fluticasone to budesonide, would there be any flare-up? Like, for example, is there any difference between the potency of fluticasone versus budesonide inhaler?
So there are equivalent doses of the two, so they're not exactly, they're not you know, 100 micrograms isn't the same as 100 micrograms, but I think 200 of budesonide is equivalent to 100 of fluticasone. That's right, isn't it, Katie? So a kid that's on 100 micrograms or 125 of fluticasone, you would put on 200 of budesonide. I think the reality is that we are pretty confident the kids are unlikely to be taking it regularly. So by flipping them to Symbicort with a PRN dosing on top of their maintenance dosing, you're probably likely to be getting more steroid on. So if anything, I would expect that change to Symbicort, you'll be able to bring the dose down because they're probably going to be taking more of it. The beautiful thing about Symbicort being both the reliever and the preventer, as I said before, is the more symptoms you have, you're automatically taking the anti-inflammatory dose at the same time. So it titrates itself. And when you're well controlled, you're barely using it. When you're flaring up, you're using more and more of it. So for that reason alone, that's why I think we'll see it creep into the younger age group as well. But yeah, to answer your question, 125 fluticasone is equivalent to that 200. So if they were on a higher dose, knowing that you can go up to 500. So 500 is where you would max out of Flixitide. We know above that you start to get side effects and you don't get any additional clinical benefit. So same, you could have 2 puffs of 2 inhalations of the Turbuhaler morning and night. But once you'd achieved reasonable control with that, you'd be wanting to step down to the 206 when you can. Well, we are very open. Oh, I think there actually are some finishing slides. Oh, yes, summary. Just recognizing that many kids do grow out of this. So we know it's very, very common in that preschool age group. 50% of those will grow out. About 1 of 3 school-age children have asthma, and then it's about 1 in 10 adults. So it is a condition that gets less prevalent with age as our lungs become a bit bigger, I guess, and more robust. But it is a constant cycle. We really encourage any child that we see in VVED or in hospital to reconnect with their primary healthcare provider, their GP specialist, so that they are getting regularly reviewed, that this education is being reinforced, that their preventer management is being optimised, that all those factors, modifiable risk factors, are being considered. And it's a constant cycle of making sure you've got good asthma control and optimising the dose and the control. Wanted to share with you, we've got a fabulous seminar coming up soon on mastering menopause for those of you who look after women of my age. Please consider coming along. It's been really popular if you haven't already registered. That's on the 18th of November, again at 7 o'clock. It will be recorded. And otherwise, yeah, please, you can claim CPD points for coming along, but even if you don't get CPD points, we would love to have your feedback, what you found useful, what you would suggest we do differently next time, what topics you'd like to hear about in the future. You can also reach out on that email address. If you've got any other questions for Katie and I, would be more than happy to respond. And if you haven't used VVSC to date, give it a go for a patient that you know is otherwise going to sit on an outpatient referral list for a very long time. Come and meet one of our specialists and see if we can help get your patient sorted sooner. Thank you all very much for attending. Katie, do you have any final comments before we wrap up?
I think we've probably covered off everything, Jo, but yeah, just again, remembering just to reach out if you've got questions or you've got, tricky patients that you're a bit unsure about the management, we're here to help. So just reach out.
On that note, actually, you can do a direct. So most of our clinics are co-consultation clinics with our specialists. For Katie's clinic, if you've got a patient that you really would like Katie to spend some time with and reiterate some of those messages, and perhaps you've got we know a lot of GPs are running very time-pressured clinics, feel free to refer them in and we're happy to spend that time with them. We would much rather invest that time and try and prevent the ED presentation. So please feel free to use that resource as well. You can register for that clinic through the VVSC Paediatric Asthma clinic, and that will get them to see lovely Katie. All right. Well, thank you all very much for joining us tonight. I am going to stop sharing and stop the recording. No, Katie's going to stop the recording. And we